Dr. Mahip Bansal. Dr. Mahip Bansal will speak to us on FLACS assisted trifocal IOL in hypermetropic eyes.
Thank you, sir. Very good morning. Today I will be speaking on hypermetropic eyes. I choose this eye for the FLACS assisted procedure. So we'll be starting with the procedure. These are normal parameters of the patient, and we have taken it to the OR. I am docking the patient, and with a very gentle push, you place the PI. Ask the patient to look into the light. You just give a gentle pressure, otherwise you will encounter some subcutaneous hemorrhages, and which you not like to have in a case of a topical. Now we are done with the rexes. Normally I go for the 4 quadrant, but being hypermetropic eye, AC depth is just 2.11 mm, so I consider to break it into 8 quadrants. So less of manipulation with the phaco probe later on. So now quadrant is being done, 8 cuts. The laser fire repeatedly on the same plane, and now you can see the cavitation bubbles coming out, and we are near to completion of the quadrant phase. So after this we'll move the patient to the cataract OT, and this is we're starting with it, and I'll make my side incision. Now you can see the EC depth is so shallow that I'm touching the anterior capsule with my MVR. So this is I'm doing with image guided system. I prefer to stain the capsule in case of femtocystis because somewhere some tags are left out which are later on very difficult to make out. So now while injecting dye also it doesn't run into the periphery, so you can make out how shallow is the EC. So just a gentle wash. I'm putting visco, and visco you can see the rexis is free floating and it has come into the anterior chamber. So gentle hydro I am giving, not much of manipulation because there's no space. In this parameter also you can make out the axial length, and AC depth is 2.2 mm. So just a gentle hydro, trying to remove the capsule with the pressure, and with the dialer I am now rotating the nucleus, being very gentle. So now I'm starting with the phaco aspiration, just debulking the cortex. So once the cortex is taken out, you can be able to make out the quadrants. And this all the 8 quadrants in the center, they are not aligned. So just align your probe to one of the quadrants in the center and go along the side of incision, and you will be able to crack it. So just debulking again the nucleus, and easily it will come out. No need of going off chopping and all procedure steps. So straight away just go quadrant wise, you will be easily able to take it out. So I prefer bimanual cortex aspiration because it gives you more space, and you can do polishing of the anterior capsule as well as the posterior capsule easily. So I plan to implant a trifocal lens in this case from BVI. So now doing just posterior capsule polishing, and this is the loading of the lens, and it has rings which extend onto the haptics. So this lens is from BVI, and this power was available in this lens was only trifocal with a toric lens. So I choose this lens. It doesn't come preloaded, so you have to load the lens. So injected the lens. Now the eye is ready to accept this IOL. It opens very gently. With a gentle push with the dialer only, it will go into the bag. Just it and it will slide in. So this was the patient, and now we can correlate with the Rexis is 5.5. So covering IOL 360 degree uniformly. And with this Purkinje image, you can make the central ring in the center of the eye on the visual axis, so that you are pretty sure that your central ring will be correlated with the pupil when it is constricted. So just look for this Purkinje image. This will guide you whether your IOL is placed in the center or not, especially for multifocal and trifocal cases. So see, on visual axis you can make the central Purkinje image is passing through the central ring, so you are sure. Just hydrate your side wounds. I'd never hydrate the main wounds because it tends to increase your surgical astigmatism. So just hydrate your side ports. That will be the done. So use of femto laser assisted in case of posterior polar cataracts in hypermetropic eyes or hypermature cataracts is there, because only added benefit of FLACS is what I feel is in case of Rexis. The most important or key to success for any your cataract surgery is the Rexis. So I was using very low IOP on 24, and my CD ratio was 2.64 in this case, because already the cataract was chopped, nothing more to do, and this was the patient next day happy. Thank you.
Thank you, Dr. Mahip, for excellent presentation. I think I agree with you that in hypermetropic eyes, most important, maybe in any of the patient where you do phacoemulsification, Rexis is the most important.
Rexis is the most important.
And here, because it may be shallow,
Correct,
anterior chamber, Rexis may be a bit difficult.
Right, sir.
Thank you so much.